في المراجعة بتاعت الموديول رقم 2 في دبلومة الأشعة أونلاين، واللي هو متعلق بالأبدومينال إيميجينج أو الجاستروانتستينال تراكت. وزي ما احنا شفنا في الموديول اللي فات، فهيكون في مجموعة من الحالات اللي هي تشبه قوي الحالات اللي بتيجي في الامتحانات المختلفة، وبنناقش الإجابات بتاعت حضراتكم عليها، سواء كانت الإجابات عن طريق الشات أو عن طريق الميكروفون العادي. وهنبتدي بأول حالة. And this is the first case of a female patient, 70 years old, with abdominal pain, and this is the abdominal scan done without contrast injection but with oral contrast administration. Okay, sorry. No answer. and if you look carefully for this study, and you can see that the gallbladder is distended with a big mass inside the gallbladder, and the mass showed some linear calcification. And you know that any gallbladder mass should be suspected as carcinoma until proved otherwise. And this is, of course, is not a calculus, because it's not dependent in the gallbladder, and it's not the size of an ordinary calculus seen in the gallbladder. So the answer is gallbladder carcinoma. The next case is an abdominal scans obtained after intravenous and oral contrast administration. I am not hearing your answer well.
Valvulus, Doctor?
Yes,
Valvulus.
this is small mesenteric volvulus, or mesenteric volvulus, and this is the whirlpool sign, which is indicated by absence of the normal relation between the superior mesenteric artery and vein, and the presence of this whirly appearance at their anatomic site. Next case is a patient admitted in the emergency room because of shock. Okay. If you look here, and you can see that there is a solid mass in the liver, and the solid mass in the liver should be considered primarily as hepatocellular carcinoma. And this hepatocellular carcinoma, one of the complications of HCC is if it is near the surface of the liver, it can rupture. And the rupture of a vascular tumor like HCC will result in peritoneal hemorrhage, as you can see here. Then this is a hepatocellular carcinoma that has been ruptured inside the peritoneal cavity, resulting in a hemoperitoneum. Next case is a female child, 12 years old, with a big mass in the liver. No, this is not the age of hepatoblastoma. Yes, it is HCC, but a special type which can occur in this relatively young age, and this is known as the fibrolaminar type of hepatocellular carcinoma. The age incidence of hepatoblastoma is below 5 years, and the age incidence of fibrolamellar HCC is around 20 years plus or minus. And the irregular type of hepatocellular carcinoma is, of course, seen in adults. The next case is a female patient, 77 years old, with this abdominal scan.
multiple lymphoma,
Lymphoma where? In which organ?
in the intestine,
Yeah, this is the small bowel. It's absolutely clear, but the main problem is here, inside the stomach. This is the stomach, and you got an enhancing mass within the pyloric antrum, and masses inside the stomach should be considered as carcinoma until proved otherwise. Of course, in the differential diagnosis, you should include lymphoma and the metastasis, but you should mention first that this should be a gastric carcinoma until proved otherwise by endoscopic biopsy. Next case is a series from liver scans obtained before contrast injection, arterial phase, portal phase.
with
Um, uh,
Giant hemangioma.
Yes,
angina,
and this is giant hemangioma, of course, because it shows peripheral nodular contrast enhancement and some pool of contrast in the portal phase. And the hemangioma, whenever it is more than 6 centimeter in diameter, you consider it a giant. One is asking about the pancreatic head and the common bile duct in this particular case of cancerous stomach. Actually, the pancreatic head is normal, and the sperm-mesenteric artery and vein are intact. The fat planes are well preserved. The only maybe abnormality here is that the common bile duct is prominent, and this considered as a normal variant in some of the patients, unless you can see an obstructive lesion that, like a stone, for example, which may lead to some dilatation of the common bile duct, and it happens that the stone has been passed, and this is residual dilatation of the common bile duct.
What about the right renal pelvis, Ustaz?
Sorry?
Right renal. What about the
Right
right
renal
renal?
pelvis, and
Yeah.
this is a very renal cyst, a very pelvic cyst or parapelvic cyst. It is not a hydronephrotic kidney because the calyces are okay. And this is another cystic lesion. This is the one of the drawbacks of this arterial phase imaging, where you cannot see the parenchyma of the kidney. You see only the cortex, and the pyramids are not yet stained with contrast material. Then this is a parapelvic simple cyst. It is not a dilated pelvic renal pelvis. The next is this CT scan obtained for the pelvis in a patient with acute abdominal pain.
Appendicitis.
Yes, and this is acute appendicitis. You got the appendicolis, which is one of the pathognomonic landmarks of this disease, and you got a stranding of the surrounding fat planes, diagnostic of acute appendicitis. Next case is an abdominal scan obtained after contrast injection, and you see the liver. Sorry, the answer is
stomach injury,
no, there is no history of trauma. Of course, you know that if there is a collection inside the peritoneal cavity and you got a scalloping of the surface of the liver and also a scalloping of the surface of the spleen, sometimes you can see it, and this is diagnostic of pseudomyxoma peritonei. And Pseudomyxoma peritonei means that the peritoneal cavity is filled by gelatinous material, and this could be due to a benign lesion or a malignant lesion. Like if a mucocele of the appendix, for example, has been ruptured inside the peritoneum, it will result in pseudomyxoma peritonei of a benign lesion. And also, some of the ovarian malignancies may produce this appearance. Next case is an abdominal scan obtained after contrast injection.
Subcapsular hematoma with laceration
Yes, very good. And this is
in the right
laceration
hepatic
in
lobe.
the liver. And there is a big subcapsular hematoma of different densities. You know, the blood, the recent blood, which is very close to the bleeding site, will be relatively hyperdense, and the blood away from the bleeding site will be relatively hypodense. And this is hemoperitoneum with subcapsular hematoma in the liver. Next case is an abdominal scans after intravenous contrast injection at the level of the liver and pancreas.
Hydrops, gallbladder,
High drops of the gallbladder. What is the cause of dilated biliary radicals?
pancreatic cancer,
Sorry.
pancreas cancer,
Cholangiocarcinoma is a very good answer, but where is this cholangiocarcinoma? It's here. You know, this is the pancreatic head, and the pancreatic head is identified by the superior mesenteric artery and vein. This is the common bile duct in the region of the pancreatic head, which is hugely dilated and is occupied by soft tissue mass. And this soft tissue mass is the cholangiocarcinoma. You know that cholangiocarcinoma can occur inside the liver and can affect the bile ducts and can affect the common bile duct as well. Next case is a patient on peritoneal dialysis who got marked abdominal distension.
bowel obstruction,
Yes, what is the cause?
ileus,
Small bowel obstruction is a good answer, and there is dilated loops with multiple air fluid levels. What is the cause?
alias,
Sorry,
Ustaz,
iliac?
PL, Elias,
Ileus. Oh, okay.
yes.
And you know that Elias is the sequelae of previous operations and so on. But if you know that this patient is on regular peritoneal dialysis, then adhesions will be the most likely cause, because by this peritoneal dialysis, you got an incidence of introducing infection inside the peritoneal cavity, and this infection will heal by scars, and these scars will affect the intestinal loops and result in this small bowel obstruction. Next case is a big
hydatid,
cystic
hydatid,
lesion in the liver. Sorry?
hydatid,
No. Hydatid cyst, one of three findings: calcification of the wall, floating shadows, and daughter cyst along the inner wall of the big lesion. But this is a big cyst with internal septations, as you can see.
abscess,
No, it's only a cystic lesion in the liver, which is towards the neoplastic site, and this is biliary cystadenoma. Is a big cyst with internal septation. It can show some calcium especially along the internal septation, and sometimes it can show some dilatation of the adjacent biliary radicals. And this is biliary cystadenoma. Next case.
Link abscess.
Splenic abscess, yes, that's right. This is an abscess in the spleen. It's relatively rare compared to the liver, but it shows all the criteria of an abscess. There is marginal enhancement of regular thickness and some very let us say, some edematous changes in the splenic tissue around the abscess. And if it contains gas, of course, this will support very much the diagnosis. Next case is a male child with distended abdomen.
hepatoblastoma.
Yes, right. And the answer is right. This is hepatoblastoma. And the age is relatively well fitting with the diagnosis. You got a solid mass in the liver of a child, and this solid mass may be single or may be multiple, as you can see here, and the mass may contain calcium. All these criteria are good for hepatoblastoma. Next case is a male, 75 years old, with abdominal distension and pain.
Sigmoid cancer.
Good, and this is the right answer. This is sigmoid carcinoma. You got the structured part of the sigmoid colon with the thickening of the wall encroaching on the lumen, as well as proximal dilatation of the colon containing multiple air fluid levels. And this is a sigmoid cancer with proximal small bowel obstruction. This is a study. This study was requested for suspected bowel obstruction. The patient, male patient, 50 years old, with distension of the abdomen and pain.
Inguinal hernia with a small bowel
Very
obstruction.
good, very good. And this is hernia. There is extension of the bowel into the inguinal canal, and at that time you should consider this hernia as incarcerated hernia, because if it is not associated with intestinal obstruction, you consider it simple hernia. But if the hernia is associated with obstructive changes, that's to say that it is incarcerated, meaning that it is not reducible. So it has resulted in this obstructive changes. Next case is CT of the abdomen without intravenous contrast injection.
Cholangitis.
Which type?
Uh, Amoebic
No.
cholangitis.
Cholangitis, I have two types, sclerosing cholangitis and biogenic cholangitis, or its other name is oriental cholangitis. What do you think?
Bionic
Sclerosing,
cholangitis.
sclerosing cholangitis is sometimes associated with stones in the dilated bile ducts, as you can see here. But the history is required to diagnose sclerosing cholangitis. The patient may have another disease like ulcerative colitis and so on. But the presence of calculi inside the dilated biliary radicals is much, much more common in biogenic cholangitis. So if you don't have the history, you should diagnose biogenic cholangitis. If you have the history that the patient had other autoimmune diseases, then you can suspect the possibility of sclerosing cholangitis. Next case is a male 60 years old with excessive alcohol intake presented by acute abdominal pain.
Acute pancreatitis.
Yes, and this is a straightforward case of acute pancreatitis. And you see that the pancreas is swollen and there is some fluid, free fluid, in the area around the pancreas without a pseudocyst formation or something like this. And this is an important diagnosis, of course, because it's frequently seen in the clinical practice, and you should not miss a case of acute pancreatitis in the daily work. Next case, patient 89 years old with atrial fibrillation.
Splenic infarction.
Yes, multiple splenic infarctions, multiple non-enhancing areas without the splenic parenchyma respecting the splenic contour, and these are splenic infarctions. Next is a male, 27 years old, with recurrent episodes of bilious vomiting and right abdominal pain for 2 days, followed by progressive abdominal distension with non-passage of flatus or feces for 1 day.
Gallstone ileus.
Yes, and this is right. Goldstone ileus is diagnosed by the regular triad, that you got some air in the biliary system and you got a radio-opaque stone in the ileum, most likely, and you got proximal to the stone some bowel obstructive changes with air fluid level, as you can see here. All this, all this triad is pathognomonic for the diagnosis of gallstone ileus. And some of the surgeons feel that this possibility, gallstone ileus, is rare in the clinical practice. I say no. We frequently see some cases like this during the daily work, and this is not a rarity. Next case is a male, 46 years old, with low left lower quadrant pain.
Diverticulitis.
Yes, and this is sigmoid diverticulitis. The sigmoid colon has a thickened, relatively thickened wall. You should see patent diverticuli containing air to settle down this diagnosis. Then you see a stranding of the pericolic fat bullains, and you may see a bucket filled with air in the pericolic area, air fluid level representing a pericolic abscess. And sometimes, if you reach the level of the bladder, you may see air inside the urinary bladder in some cases. Next case is a male, 85 years old, with vague abdominal pain.
There is pneumoperitoneum.
Pneumoperitoneum. Yes, and
Yes, and pneumobilia.
pneumobilia. These are the bile ducts
In the
of the
aortal
portal
vein.
venous radicals.
What aortal vein? Yeah.
Yes,
Mesenteric ischemia, doctor?
yes, and the answer is right. And you know that the biliary radicals do not reach the peripheral part of the liver, but the portal venous radicals can reach the subcapsular area. This is number one. Number two, you can see air in one of the major branches of the portal vein. Number three, and you see air in the superior mesenteric vein, meaning that there is an intestinal ischemia. And this intestinal ischemia is also diagnosed by the presence of air in the wall of the intestine and the presence of
Pneumatosis intestinalis.
enhancement of the
Yes.
affected intestinal segment. Then this intestinal ischemia may be complicated by pneumoperitoneum associated with ascites. And you know that The presence of air in the portal venous system is one of the dangerous signs, especially in adults. And this sign is considered somewhat terminal, because whenever air reaches the portal vein, you know that the patient is about to die. And this is the opposite of air in the portal system of a pediatric age. This can be seen in patients with necrotizing enterocolitis, and this is not a bad sign or a sign of terminal status for the patient. This is ischemic bowel with air and fluid in the peritoneal cavity, air in the wall of the intestine, air in the superior mesenteric vein and in the portal vein. Next case is a series of MR enterography. Uh, yes. Okay, and I hope that you have listened to the lecture about the MR enterography. This is a new one I added to the contents of the course. And you know, before from the regular lectures that the small bowel do not contain filling defects. The small bowel contains fluid only. But if you see multiple filling defects within the small bowel, you know that these are polyps. But filling defects are routinely seen in the large bowel, and these are, of course, due to fecal matter. But in the small bowel, you should consider polyps, and the most famous intestinal bulbosis syndrome is that the Budd-Sugar syndrome. This Budd-Sugar syndrome is diagnosed just if you look to the face of the patient with the characteristic circumoral pigmentation, and also there may be subpigmentation in the hands and polyps everywhere in the small bowel, in the stomach, and so on. Next case.
Aortic aneurysm. Aortic
Yes,
aneurysm.
aortic aneurysm, and there is another lesion which is more important than the aneurysm itself. Okay, you see this mass, which is a solid mass enhancing, heterogeneously enhancing, or let us say homogeneously enhancing, and this is the site of the lesion. What do you think?
Ileocecal area.
A little bit away from the ileocecal region. Okay, if you are confronted by a lesion like this, when you are not able to adequately locate the lesion, whether it is in the mesentery or it is in the bowel, then if it is in the mesentery, it will represent carcinoid syndrome, carcinoid tumor. If it is in the bowel, the first possibility should be GIST tumor. Then the other alternative for the diagnosis, as I have mentioned every time in the lectures, that you should mention the primary lesion in this particular area to be followed by lymphoma and metastasis. Everywhere in the body, these three possibilities should follow each other. Then, if you are asked about this lesion, and you see that if you see that it is of a small bowel and see this is GIST tumor, what else you say lymphoma? What else you say metastatic disease? How can you discriminate between carcinoid tumor and GIST tumor? Carcinoids are usually strongly enhancing, and they introduce reactive reaction in the reactive fibrosis or fibrous strands, which can produce some sort of retraction of the mesenteric fat, and this usually characterize the carcinoid tumor. Then this is GIST tumor, and this is aneurysm. It is an incidental finding. This patient, 53 years old, mentally retarded, was brought to the emergency room after vomiting a plastic glove.
Gauty
Yes,
bipolar.
this is gastric bezoar or goosey bimboma. The stomach is markedly distended by abnormal anatomical and air and speciated between the other contents. The diagnostic of gastric bezoar. Gastric bezoar is different from goosey bimboma. I don't know what is this, but okay. Goosey bimboma is missed without surgery, but this is inside the skull. If anyone can stop this noise, it will affect the recording. Okay. Next case is a male, 24 years old, evaluated in the emergency department for a 2 weeks history of worsening bloody diarrhea with up to 7 bloody bowel movements per day. I'm not getting your answer because of this very noise. Yes, they have toxic megacolon is the right answer. And you know that the toxic megacolon may affect primarily the transverse colon, and that diagnosis is settled if the diameter of the transverse colon exceeds 6 centimeters. Okay. Next case is patient presented by right pain and fever. Actually, some questions present right time. So if anyone knows the topic, he should close the microphone. Okay, the right answer is Caroli disease, as mentioned by one of you, and there is a cystic dilatation of the biliary radicals. How you know that? How you know that these are dilated bile ducts by the presence of other tubuli dilated bile ducts in the left hepatic lobe? And how you know this is Caroli disease by the presence of these dots on each side of the bile ducts, which represents the portal venous radical characteristic of Caroli's disease. Next case.
Recent study, دكتور؟
Sorry. abdominal pain.
Mucin, cystadenoma, pancreas.
No. This is actually the common bile duct, which is markedly dilated. If you go to the terminal end of the common bile duct, you see nothing. And if you go to the intrahepatic biliary radicles, they are not dilated. And if you look to the coronal reformatted image, you can see this appearance. This is characteristic of
Colorectal cyst.
yes, and this is local cyst type 1, where you got dilatation of the common bile duct. Next case. Yes, and this is polycystic disease of the liver and the kidneys. Many cystic lesions in the liver and many cystic lesions in the kidneys. And this is polycystic disease of the liver and kidneys. Next case.
Gastric lymphoma.
اوكي. بعد اذن حضراتكم، يعني الشخصية اللي هي فاتحة الميكروفون او فاتحة السماعة نقفلها، علشان دوت بيشوش على الباقيين، ومش من مصلحة اي حد منكم ان التليفون دوت يطلع مشوش او يطلع مش مسموع كويس وكده. فالشخص اللي هو الصوت بتاعي بيرن عنده يقفل الميكروفون بتاعه لو سمحت. يا دكتور شريف، طبعا هو ساب الحكاية تجربتين وراح خارج وجاي صرف صوت. يا دكتور شريف، هو حضرتك معايا ولا بتعمل حاجة تانية؟ ما حضرتك بعد إذنك ادخل على البتاع، اقفل الميكروفونات بتاعت كل المستمعين، عشان الهمبرية اللي بتحصل دهيت تخليهم يجاوبوا. على كل قلت الدكتور شريف ان هو يقفل الميكروفونات بتاعت حضراتكم كلكم، طالما ما فيش اي نوع من الاستجابة للكلام اللي احنا بنقول عليه. فالحالة اللي بعد كده لما الميكروفونات اتقفلت حد قال ان في ست gastric carcinoma، وديت تعتبر إجابة صحيحة، لأن المفروض إن الجاستريك كارسينوما بتعمل disease thickening of the gastric wall وبينكروتش على اليومن، وزي ما أنا قلت الأنسر اللي هو differential diagnosis تجاوب بأن الليمفوما هي اللي بعد كده وبعدين الرينال سيل. This patient has proved to be gastric lymphoma after endoscopy. Next case.
اتفضل يا دكتور ممدوح، أنا آسف.
شكرا. Next case is a selected film from an MR enterography and showing a very characteristic sign of Crohn's disease. Okay, then I have mentioned in the recent lecture that one of the diagnostic criteria of Crohn's disease is the Combe sign. And this Combe sign is the result of dilated vasa recta vessels along the mesenteric border of the affected lobe. And this is one of the best diagnostic signs of active or acute Crohn's disease, is known as the Combe sign. Next case is a female patient presented by abdominal mass. Wandering spleen is the right answer, and this is the spleen, of course. It should be located in the left hypochondrium, but whenever the spleen it is not in its normal anatomic site, it appears very large compared to the usual size of the spleen. And frequently, it lies transverse in the pelvis with its hilum facing downward, and sometimes there is rotation around the splenic pedicle, resulting in total splenic, what is known as splenic torsion or total splenic infarction. This patient underwent a cesarean section. 3 months later, she presented by abdominal mass, pain, and fever. المفروض ان you answer through the chat. Don't use the microphone. Yes, and this is goosey biboma or retained
Dr. Mumdouh, please join audio again.
Okay. And this is retained gauze. How can you know this missed towel is by the presence of radio-opaque material, which are present in every surgical gauze to identify it even by the plain X-rays. Then you got air entrapped between the meshes of the retained bowel, and you got a significant inflammatory reaction resulting in what looks like a wall, but this is a inflammatory granulation tissue surrounding the retained gauze, and this is gauzy pupoma. Next case. Yes, and this is mesenteric panniculitis, which is one of the frequently seen lesions in the clinical practice. And they are frequently either missed or interpreted as lymphoma or other possibilities. Mesenteric panniculitis is an inflammatory reaction in the mesentery, and it results in an abnormal haziness of the mesenteric fat with a very characteristic fat halo sign around the mesenteric vessels. The layer of fat that is spared around the mesenteric vessel is one of the diagnostic criteria of mesenteric panniculitis, and is known as the the fat halo sign or the fat ring sign. Next case is an abdominal scan after oral and intravenous contrast injection. Okay, and actually, um, if you see that most of the pancreatic tissue has been replaced by a big mass containing air, this is a diagnosis of either pancreatic abscess or acute pancreatic necrosis. Both can fit for this appearance, where you see that the most of the pancreas is replaced by fluid and gas. These changes affects also the pancreatic body and the tail, with of course some reactive inflammatory changes in the adjacent peritoneal fat. Next case. Yes, and this is Xanthogranulomatous cholecystitis. You know, we have Xanthogranulomatous pyelonephritis in the coming module, and Xanthogranulomatous cholecystitis, where you got inflammation of the gallbladder wall and marked thickening of the gallbladder wall, which may be sometimes mistaken for gallbladder cancer. The only differentiating point is the presence of cystic changes in the thickened wall. And if you got some sections in the liver, you will see that the adjacent liver showed significant inflammatory reaction. These are diagnostic for xanthogranulomatous cholecystitis, which should not be mistaken for carcinoma of the gallbladder. Of course, both lesions will be removed surgically, but the xanthogranulomatous cholecystitis is a benign lesion, while carcinoma of the gallbladder is a malignant lesion, of course. Is there another lesion in the pancreas? And you can look. Where is the pancreas? The pancreas is not included in this section, and this is a small bowel. And this part of the colon, of course, filled by gastrographene. These are the mesenteric vessels which appear prominent. Next case is a scan obtained after intravenous and oral contrast administration. Okay, and an answer is metastasis. Another one is lymphoma. And let us start by location of the lesion. Do you feel that this lesion is in the intestine or in the peritoneum? If you feel that is in the intestine, the first diagnosis should be lymphoma, because lymphoma is the lesion that can extend outside the lumen to infiltrate the adjacent peritoneum, and you got many of the enlarged lymph nodes in the vicinity of the lesion. But if you feel that this is a peritoneal pathology, then lymphoma will be also in the first uh, and the first is the first choice, followed by metastatic disease. And metastasis usually affects the omentum and result in an omental cake. But if you see some intestinal loops going through the lesion, then you feel that this lesion has originated from the small bowel and infiltrated the peritoneum. Next case. No, the previous case is not an omental cake. This is not the site of the omentum. The omentum is a little bit higher, and it lies immediately underneath the anterior abdominal wall, and it does not surround the small bowel. On the contrary, the small bowel are displaced posteriorly by the omental cake. Next case. Yes. Hydatid cysts is the right answer. And you got two or three hydatid cysts. Some cysts are in the liver, and this lesion is maybe considered in the peritoneum or in the lower bowl of the spleen. It does not make much difference, but these are multiple hydatid cysts, and you can see clearly the daughter cysts located within the original cyst. Next case. Okay. Yes. This is an easy diagnosis, and you got the coffee bean sign. The sigmoid colon is markedly or hugely dilated and bent on each the two loops are forming the characteristic coffee bean sign, and this should not be mistaken in the plain film for any other diagnosis. This is an emergency, and the sigmoid volvulus and also the cecal volvulus are one or two of the lesions that cause abdominal pain and distension, and they are considered surgical emergencies. هذا وبالله التوفيق. شكرا جزيلا.